All right, everyone. As promised, I'm going to finish off my lecture, and we had stopped at the high altitude emergencies. This has always been a kind of a special interest to me. The physiology is interesting, and being able to prevent it's important as well. You might recognize this mountain in this picture. It's actually Mount Shasta in California, which is fun to climb. It's about 14,000 feet, and it's a challenging mountain, but it's fun to climb. It's not super hard compared to other things that are around. And so we're going on to the next slide here. So basically, acute mountain sickness is the idea that if you climb up high above 8,000 feet, you get into a hypoxic environment. So Provo is about 4,500 feet, and as I mentioned in class, if you were to bring somebody up from a lower altitude like sea level and they hit them in a mountain, then you're going to have problems you could potentially have problems. For example, if you have your friend or somebody come from from low like sea level area and then they try to climb Timp, that could be a problem. And you have and basically what happens is you'll have the mechanism is that you have somebody that's so we have the mechanism is responsible for hypoxia at altitude. Basically, if you think about it, the oxygen percentage at sea level is 21%. So oxygen is 21% of the air around us. On the top of Mount Everest, the oxygen level is still 21%. It's still the same amount of oxygen. However, what happens is the barometric pressure drops because of the altitude, and you lose that oxygen exchange in the lungs because the partial pressure of oxygen is lower, and you're not able to push it into the body. And so people become hypoxic because there's not that transition of air in the alveoli in the lungs. And so really it's not an oxygen problem so much as it's a pressure problem. And so if you were to manage somebody's to help somebody, it's kind of important to understand that, and we'll talk a little bit about how that's important. But acute mountain sickness can come in about 7,000 to 8,000 feet. There's also acute ultraviolet keratitis, which is basically snow blindness. So when you're up really high and the ultraviolet light is higher, you're going to want to use glacier goggles or some kind of goggles because the light is going to reflect into your eyes, and you can actually burn the corneas and cause burns to the eyes, and they call it snow blindness. So a couple of reasons why you want to protect your eyes at altitude and you're worried about acute mountain sickness. So high altitude, like 14,000 feet, and then you're very high, you get up to like 18,000 feet, which is more like Denali, which is over in Alaska. And then you get up really high and you're 29,000 feet, and that's like Mount Everest level where you're getting like really high up in the mountains. So those are things to kind of think about in terms of how to, like extreme environments. So can you get altitude illness here? Sure. But can you really get it when you get really, really high? Of course, that's important. Another thing might happen is like a decompression in a plane. So if you're flying in an airplane, the plane cabin is pressurized to about 10,000 feet. But planes often will fly at 29 or even 30,000 feet or above, which is higher than the altitude of Mount Everest. So if the plane were depressurized suddenly, everybody would go unconscious because you're losing that pressure in the air around them. And so pilots are trained, if there was a decompression thing, basically the pilot's first task is to fly the airplane down to 10,000 feet to mimic what that cabin pressure should be. Or the people basically can get high altitude illness in those cases. And then hypoxia is also greatest during sleep. So if you're sleeping at an altitude, like you come up to altitude and then you're sleeping at that altitude, it can be really dangerous, and you get hypoxic episodes during your sleep. So climbers will tell you to sleep or to climb high and then sleep low, and so you want to come back down to a lower altitude when you finally sleep. So basically, you get acute hypoxia, dizziness, lightheadedness, dim vision, nausea, vomiting. You can get it really the headache. You can go unconscious, as I talked about, acute decompression in like an airline situation. So you get the headache, GI disturbances, dizziness, and so there's a scaled score called the Lake Louise score. It's really used for research, but basically it delineates a score of and including the headache, the dizziness, fatigue, poor sleep, and it gives you kind of a scoring system on how bad this altitude illness is for this person. The way you prevent it is you do a staged ascent. And this is kind of basic mountaineering stuff where you would go up to altitude and then you let yourself acclimatize, and then you're going to go higher after that. When you're coming up to mountains around here, you probably wouldn't need to acclimatize to just go up to the top of Timp or something. But in a higher altitude, you would want to sleep at an altitude of maybe, like people that go into the higher mountains like Fort Teeners in Colorado, they'll hike up to 10,000 feet and sleep, and then they'll go up and do an ascent and come back down. And they might do that to do like a staged descent, where if somebody were to come up here from California and then they suddenly climb Timp, the next day it may not be good for them. But if they were here at altitude for like a few days and then they climbed Timp, it might be better. But they could still get altitude illness. The treatment, as we talked about in class, is to descend immediately. That's the best treatment. When somebody's they climb up high, and it can be confused for maybe they're not feeling well, they're getting a little bit sick, they start throwing up, maybe they're dehydrated. But if they're eating and drinking water and they're still getting sick and they got a little mild headache, and then maybe you can get a little bit confused or fatigued, you need to go down. People that are doing it in like sports physiology, they're going up to really high altitudes, they might use acetazolamide, which is one where it decreases. So basically, if you think the physiology, what happens is the body responds to the low oxygen by breathing faster because it needs to exchange oxygen quicker because it's starving for oxygen. But that produces a respiratory alkalosis because they're hyperventilating. And then in order to compensate with the alkalosis, the body needs to excrete bicarbonate and basically needs to decrease the resorption. But that doesn't happen right away. And it does happen over a few days where the kidneys start to decrease the reabsorption of bicarbonate, which is the buffer for the blood, and trying to reverse the alkalosis that's happening because the person is breathing fast. And so they use acetazolamide, which basically enables that to help with acclimatization by decreasing that bicarbonate. And it also, and then eventually the body, if it stays at altitude long enough, EPO kicks in, erythropoietin, and you start making more red blood cells. The blood gets a little thicker, your hematocrit goes up, and the person's more fully acclimatized. But that can put them at risk because the hematocrit can go so high that the blood's getting too thick, and it could cause a problem with strokes and stuff like that as well. So mild AMS, or mild mountain sickness, is no further ascent, descent to lower altitude or one that you felt well at. You could do acetazolamide, and then a lot of times people just use ibuprofen, prophylactically, maybe an antiemetic like Zofran, and you can kind of overcome kind of mild illness. If it starts to get worse, then you need to get them down quickly, and you need to descend a lot faster. And then you can get low flow oxygen going, again, acetazolamide, and then you can get a hyperbaric therapy. So high altitude cerebral edema is one where somebody starts to get progressively altered mental status, ataxia and stupor. They're walking around it raised intracranial pressure secondary to edema in the brain, and it can cause problems there as well. And then that high microvascular pressure, it can turn into pulmonary edema as well, and we call that high altitude pulmonary edema, which is where the lungs are filling up with fluid. That's obviously super dangerous. They're coughing, they're not breathing well, and then it progresses to, they have this cardiac tachypnea, and then they have this cough that worsens, and then you get altered mental status, and eventually you go into a coma. So for immediate descent or evacuation, of course, so high altitude cerebral edema, they're taking dexamethasone. You can get a hyperbaric chamber. And then HAPE, which is high altitude pulmonary edema, you can use immediate descent, oxygen, nifedipine, and then you can get them into a hyperbaric chamber. And I keep saying a hyperbaric chamber, and one might ask, how does one do that in a high altitude environment? They have a thing, I'm going to look it up real quick. So they have something called a GAMO bag, which stands for, well, I don't know what it stands for actually. I think it's the name of the company that makes them. But basically it's a bag that they can put somebody in here. I'll show you kind of this picture maybe right here. Where are we? Maybe that one? Hang on. There we go. So this is an example of a Gamo bag. So there's a person inside that bag, and what they do is they pump up the bag, and it creates a pressure inside the bag, which then increases the pressure around the person. So they don't necessarily need air or oxygen so much because the percentage is fine. It's they need the pressure from being at a lower altitude. So they'll put somebody in this bag and let them sit in there for several hours to try to recover, and they could do that to kind of save somebody or, like, in a sense, rescue them from that. So they do have those. You can pack them in a backpack, and you pump it up with a foot pedal. It gives a pressure gauge, and you can basically save somebody's life. And they have basically what amounts to a temporary hyperbaric chamber that you can use in the field. So pretty ingenious way of doing those kind of things. Let me get back to the lecture here. So that's kind of your overview of high altitude illness. And if you're going outside and you're up in the mountains and stuff, it might be something to think about when you're dealing with somebody who starts to have a headache, they have a little nausea and vomiting. We had a trip up Mount Shasta when I was probably 15 years ago now, and one of the people in our hike got really, really sick. And the treatment was down. He had to go down really quickly. And the guy that was with us basically told him to drop his pack. We separated his stuff so he wouldn't have to carry anything. He tied a rope to the guide, and then he had a long line of about 20 feet, and they just hiked down really quickly. And that was his treatment. So electrical injuries, we'll go into lightning and electrical injury strikes or lightning strikes. So electrical injuries, kind of everything burns, the skin burns, but it can be thermal burns, direct tissue, and it can cause some numerous life-threatening stuff. If you get a really solid electrocution, you're basically injuring the whole system, renal, respiratory. They can go to seizures and then go into cardiac arrests. So the skin injury that you might have when you're playing around, like you stick your finger in a plug socket or you have a live wire, the skin injuries may not actually reflect the amount of damage that's internal damage from an electricity burn. You might say a small burn on the hand, but in reality, they have significant internal injuries. Diagnosis commonly based on history. All the altered mental status could be from lots of reasons if this was unwitnessed. You want to get, but you're going to think about, like, did they injure themselves? Are they, as far as that goes, because you have somebody that falls, hits their head, they're found, they don't really know that they were electrocuted. Okay. So you do an EKG, get an arrhythmia check, CK, myoglobin, head CT for AMS, and you're going to be looking for other things while you're simultaneously looking to see if they were injured. And hopefully there's some clue that they were electrocuted, but you may not know that. Treatment, ACLS protocol, spine precautions, potentially. Admission for, like, a lot of cases, unless it was a simple thing that was just a household thing, and maybe the person's not particularly hurt. Abuse and neglect, pregnancy, potentially. Treat burns and bony injuries. Treat as if it's a trauma patient. And then lightning strike, that's a whole different ballgame. So this is a really high voltage, but it's very brief, which is helpful. So it's more of a flashover. So it's the heat, the shock wave, the noise can blow the eardrum out. They have trauma to the ear. When this happens, they potentially go into cardiac arrest. But it's like a flashover electric injury, different from if you were to, like, have a sustained injury from, like, a live power line or something. Person might be in cardiac arrest, might have seizures and burns. There's a ferning pattern. So this is kind of a fern-like burn where it kind of lays over and you get this, like, burn and kind of it's like a fern, like a plant kind of shape to it. So that's kind of indicative of a lightning strike. Transient weakness and then blunt trauma, potentially compartment syndrome could be a possibility. So may require pre-hospital triage. ACL, probably will. Well, triage meaning if they have multiple victims down, like you hear stories of, like, a lightning strike that hits a soccer field and there's multiple players on the field and the grass is wet and it travels along the ground and you have multiple victims in a scene where a lightning strike might have occurred. Here in Utah, we have a lot of summer lightning storms. And I remember one time I was at my kid's soccer game and they called the game because of lightning, but nobody left the field. They were all standing around. They weren't playing the game, but they were still out in the open. It was kind of crazy. And my daughter's team was all huddled around a big group of like 20 kids, and they're all just huddled in a group around the coach. And I'm like, they called the game from lightning. Why are you guys all standing in a little group? Like, get out of there. All the spectators were like in their cars, but So I ran over there and grabbed my own kid, and I was like, just get in the car until the lightning passes. Anyway, so treat injuries, treat seizures, maybe a tetanus shot. And we're going to wrap up here with carbon monoxide. Just a few more slides. So carbon monoxide is where you have fire, smoke, exhaust, gases, burning gases. So open fires, open flames, maybe a pilot light that's not out, or any kind of like gas leaks, things like that. It could be natural gas appliances, things like that could cause gas leaks. And you got to remember, interesting fact is when you smell gas, you're not actually smelling the gas. The gas doesn't have an odor. But for safety's sake, they actually add, and I think it's, don't quote me on this, I think it's hydrogen sulfide. Something about, I think it's hydrogen sulfide. Anyway, they add a gas to it to make it smell. And so you can tell that it smells. But normally carbon monoxide and gas may not actually have a smell. And so when you're looking at, say, gas from like a stove or something like that, if that hydrogen sulfide that hasn't been added, it doesn't smell like that. So you might miss it if you were just like in your car. Like the exhaust from your car is a good example, might produce carbon monoxide. 1,200 deaths per year in the United States. We just had one in Utah at the beginning of the summer. There was a guy that died from carbon monoxide in his tent while he was camping. So it's an odorless gas. Again, they add the gas to make it smell. And for life of me, I can't remember what it's called. All right, you guys can Google it. But basically, carbon monoxide doesn't smell. It doesn't have a smell to it. So somebody might have, number one, you might have multiple victims in the same household that all got sick at once. That's a possibility. A person might get headache, nausea, tachypnic. They might have seizures. They go into a coma. They become unresponsive. And chronic exposures do occur. It tends to cause kind of redness in the skin. But the main clue might be that they are basically pretty healthy, and then they get this carbon monoxide. And if you have multiple victims in the same household, that could have been a problem as well. And what happens with carbon monoxide is it competitively competes for oxygen, carboxyhemoglobin, in our hemoglobin. Basically what happens is instead of carrying oxygen, the hemoglobin are carrying carboxyhemoglobin, which doesn't release into the tissues, and the body can't use it for oxygen exchange. So the classic thing is the cherry red nails, mucosa, may be seen post-mortem. Standard oximetry doesn't pick up on carbon monoxide. So you might put a oximeter on them and it says it's normal because it's not distinguishing between the carboxyhemoglobin and regular hemoglobin. And the half-life of carboxyhemoglobin is about 5 hours. And this is considered something that may be part of a suicide attempt or potentially an event of self-harm. So you got to be careful and maybe potentially assess them for suicide depending on the context of what happened. So you want a co-oximeter. This is one that can measure the total hemoglobin, the oxyhemoglobin, and the carboxyhemoglobin saturation. It gives you the differences between them. So it's a special meter that's beyond just a regular O2 monitor that you might use on somebody's finger. So that might be your first clue as far as what's going on. And then you want the highest concentration possible of oxygen. So you're going to they use hyperbaric chambers. They put them in there and they just expose them to a high concentration of oxygen. And you're trying to compete for the carboxyhemoglobin on their hemoglobin as it's carried around the body. Go observe for about 6 hours, 100% O2. Watch for like neurologic sequelae and other possibilities with that as well. Okay, so carbon monoxide poisoning is a very serious thing that comes up every once in a while as well. So that's the end of the lecture. My mom actually got me a t-shirt once that said, "Think outside, no box required." And you can see that there's a lot of opportunities in Utah to go out and have fun in the environment. Just be careful, be safe, and think about, try to mitigate risk and don't take things too cavalier when you're going out and doing stuff that's, pay attention to the weather, especially if you're doing slot canyons. You got to make sure there's weather. You want to worry about flash floods and wear your life jackets. And thanks for listening, and we'll end this lecture now.